By now, you're familiar with the case count. We have 566 cases of coronavirus recorded in Ghana. And we'll bring you what the breakdown is. But let's also take you and bring you up to speed with the latest, not only the local, but the global figures we have. After this, we'll speak to a public health consultant and an expert on the subject. And the total confirmed cases, 566, also indicating to you where they have been recorded regionally. We'll do that. And if you look at the regional breakdown, we do have for the Upper West region a case of 7, East 4, and particularly for the Upper East region. The first initial case and its contacts were the ones that resulted in the 3 others, making it 4. Northeast and Northing, 1 and 10 respectively. And public health officials have been able to atomize or intimate reasons why we have increasing cases in Greater Accra, which so far is pegged at some 452, but followed closely by Ashanti, 49 in the eastern region, and 32, the bulk of them coming from those workers of AFCONS, the construction of the rail company working on rail lines and its construction subsequently within the Lower Manya area, even though at Fantiakwa a case has been recorded. Central region still has 1, but it speaks to the general situation of the breakdowns we have. We'll take you to the eastern part of our country and also get to know what's the current state of cases of coronavirus. Western region having 1, but the Volta region, of course, which is sandwiched between Accra and the eastern region, also experiencing 9 cases. Well, and that's the Ghana situation, but generally, you go to the world and we have 1.9 million. We're counting, inching closer to the 2 million mark as a globe. And it's North America where we have the bulk of the cases, some 582,000 cases. And the New York area is where the United States government, including mayors and county heads, trying to put heads together and grappling with the situation. But you still will find a number of cases in Detroit, Chicago, and Louisiana, New Orleans, Atlanta, Georgia, Miami, because you look at the coast there, and you have a lot of, but Washington State also is experiencing the surge in cases as well. But on the worldwide figure, it's Spain that follows the United States closely, and then we have Italy, we have France as well, Germany, and then the United Kingdom. And Italy, Spain has 170,000, Italy has 159,000, France 137,000 and counting, Germany has 130,000, United Kingdom 89,000, 83,000 still for China, and China has not had a surge in cases, even though recently we've had some incremental cases being recorded, and even some negative, or those who had recovered from coronavirus are getting reinfected. What officials, that health experts at the WHO and across the world have not been able to establish, because they're still undertaking studies, is to find out whether if you are infected and you recover, you develop some sort of immunity towards it. Of course, at the level of the international partnership and the discussions published across many medical journals, also, you know, tinkering with the idea about whether herd immunity could also be looked at. So we'll see how it goes. But that's where we transition and come to Ghana, because 566 from that 400 and something mark also shows us that we're just counting the cases as they are. Now, there are bigger questions related to public health that we need to ask. Dr. Paul Osodro is a public health expert and a consultant, also teaches within the profession of allied medical science. And so we'll have him on stream and ask him some critical questions. Because if you take the initial case counts, Kumasi, Obuasi, Accra, Tema, since then, over the last 1 month, we've now moved to almost every region with the exception of a couple, about 5 or so, or 6. Okay, that speaks to the general state of how incrementally we've been able to record the cases. Dr. Paul Osodro is on stream. Good morning to you, sir.
Good morning, Roland. I hope you are keeping safe.
I try my best. I try my best. Now, what has been your observation by way of the trajectory of the cases that have been recorded across the country since we last spoke over the last 1 week?
Okay, so I think during our last interaction, I made mention of a terminology we call the R0 in epidemiology. If you look at this virus, the R0 is quite high. It is estimated between 2 and 4. So what it means is if someone has the infection, during the period that the person is infectious, he or she can transfer 2 to 4 people. And those 2 to 4 people will also transfer to about 2 to 4 people. But even this factor is dependent on social structures and all those things. So in a country like Ghana, where some places are densely populated, you may have a higher R0 than what has been established. So with this virus, what it takes is to introduce one person into the society. And in a short time, because of it high R0, you start seeing this. So it is actually not strange that we are seeing this.
Okay, and I was listening to the chief of public health for the United Kingdom, and in relation to these knots that he said, he gave an example of the UK just hovering the numbers of 2, and almost like almost like ours, but they have a different population density to us. If you look generally across the communities that we have, why should we be adopting the same scale of measurement, so to speak?
In terms of the R0 or what?
Yes. To get to know, to get to know the rate of infections. No. We cannot use what is pertaining in other parts of the world. We look at a peculiar situation, and as I said, in Ghana, there are places that are densely populated. Look at Old Fadama, for example. Someone is infected, the R0 there is going to be more than the 2 or 4 we are estimating. It could go as far as 10 because of the nature of interactions we have there. So what is stood out there is generally what you expect to see, but depending on your peculiar situation, your R0 could be higher than what are estimated. We have to talk generally about the cases, and we will let you also have a hand as you contribute significantly to this discussion to get to know how the testing is going and whether you think that the way we're undertaking it as a country is the best way to go. Because we do know that Noguchi initially was the foremost center for which we had the test being undertaken, and then we went to Kumasi as well. Now we've brought in the scope, Kolebu is part, but we'll also look at key questions about how we need to or not increase testing and whether that could also complement the efforts that we need to undertake. And then what responsibility lies with our citizens to make sure that we're able to do this? Because if you do analysis of some of the cases, especially for the Volta region, where we're told that majority of the cases that were recorded, and they have 9, we have at least people who have traveled apparently from Accra and Tema and even Ashaiman, I read, and they had recorded the cases. Okay, so you're back on stream. Now, if you look at the case count so far, what could be the explanation for the spread to other regions, knowing that Accra seems to be the epicenter for Ghana, over 400 cases, and you look at Volta, Eastern region, and geographically that spread going as high as it should? What could be some of the explanations that you could give?
Accra is a cosmopolitan area. A lot of activities do happen in Accra. You get people traveling all over the country to Accra to transact business. So if they come and then they catch the infection, definitely they are going to take it back home. I think out of the 9 cases that have been recorded in the Volta region, 2 of them actually went from Achiama to that place. And so, I mean, if you have this kind of movement, and we know with the virus, the faster you move, the faster it moves also. So once people are moving from the epicenter, then chances are that they will be carrying the infection from the epicenter to places where ordinarily it wasn't there. So that basically explains this. And that brings me to how we planned the lockdown. I think it was poorly done, and that might have contributed to the spread of this virus to other parts of the country.
Okay.
Because if you notice, a lot of people moved out of Accra prior to the imposition of the movement, restriction of movement. So if those people were carriers, definitely they are going to introduce the virus into their communities, and then it will begin to spread. So in my opinion, I believe that is part of it. Also, from the northern part of Ghana, we know our borders there are not that secured. You may get people moving in from Côte d'Ivoire, Burkina Faso, and these places have reported cases. So if we have movement of persons from high-risk areas into your region, definitely it may also account for some of these cases we are reporting in places outside of Accra.
There's a profound comment that I saw from a medical doctor on Facebook, and he was saying the public health strategy and the lockdown should have been in tandem on the ground. And he was thinking perhaps apart from just temperatures, etc., we could have done something better than maybe on ground, having a health person at maybe roadblocks or maybe where we have exit or entry points. For public health strategy, how does that work by way of trying to have a dual action be undertaken, a lockdown, barriers, but public health personnel also stationed there?
With this virus, what is most important is how to take care of the asymptomatic patients. So if you have roadblocks with public health personnel and you have asymptomatic patients moving through, they wouldn't be able to pick them up. But public health goes beyond infection control. Public health is broad. There is an aspect we call health promotion, which look at policies which affect the income, food security, employment, and all these things. Yes, so lockdown is okay. It limits movement and therefore it's the spread of the infection. But there are other aspects of public health, which in my opinion was not looked at, or the lockdown was not planned comprehensively around public health. We're only interested in the epidemiology, which was the infection control. But the other aspect of public health, was ignored. And that would be part of the reason why we are seeing a breakdown in the restriction of movement, especially in Accra and the greater places. And if we are unable to get around this, I am afraid to say that the lockdown would be an exercise in futility. We may not be able to achieve the intended effect if we don't address some of these public health issues.
And the intended objective or rationale for the lockdown is what in relation to public health?
It is to slow the rate of transmission of the infection.
Okay.
The lockdown will stop the epidemic. It will only slow the rate of transmission so that we can move people out. And because the numbers that our health system will be. But if you impose a lockdown and you fail to identify those who are carrying the virus, what you are technically saying is if you will infect people within your neighborhood. And I don't think it's also fair to expose everybody in the neighborhood to such risk when it was not their doing.
Because speaking to all the talk about the infections and the numbers that have been recorded in Tema and Ashaiman, for example. You take Ashaiman particularly, and majority of the population density has semblance to how Sukura, Nima, Malmobi, and then Newtown is. There's a lockdown, the streets are empty, but people still live in compound houses, they share toilets, they share bathrooms, all right, and even eateries where they buy food is at a central location because you don't even have enough space for a kitchen for you to go and cook, etc. They still take trotro within the centers because the police don't patrol enough in the communities. They are at the main centers, etc., on the main roads. Just take me through. How has that contributed to the case count?
It is possible that it might have contributed quite a lot. But ordinarily, for example, a person who lives in Ashaiman, who will probably move to, say, Ingo or Pram to do business, now is limited to only Ashaiman. So if such a person would have infected, say, 10 people ordinarily in his daily activities, because his movement has been restricted, he may probably infect about 2, 3, or 4 people. But those persons will be within his community or the places that he will travel to within the community. So still, the infections will go on, but we expect that with limited movement, such infected persons wouldn't infect quite a lot of people as compared to if the restrictions are not being imposed. But as I said, the restrictions alone will not extinguish the flame. We need to move in, pick out everybody that's infected, including those that are asymptomatic, so that the community will be free. Another thing is the essential service workers who work in the communities. They move in and out. So with this enhanced contact tracing and testing, if the team goes into the community to do the cleanup, and then someone who is an essential service worker returns to the community, we don't have any means to ensure that that person doesn't return into the community infected. Because if such a person carries an infection outside and enters the community, the exercise that has been conducted is a zero. So we have to look at this comprehensively. Other than that, I am afraid to say that we may not be able to fight this pandemic.
In order not to be giving the general or the blanket statement, but also being real, if you look at what we've done so far, what have we done wrong? Well, is it the contact tracing? Is it perhaps our inability to test people enough based on what we have traced, or we've just not been able to get have a turnaround for enough tests?
The problem is we have limited resources, so we try to make do with what we have. WHO is recommending testing, testing, testing. And the main reason why we have to test is because of the asymptomatic person. Those who will show signs or symptoms with proper education, they will definitely call the hotline, and they wouldn't cause any problem for the community. But those that are asymptomatic, that you can only identify by test. If you don't test, how do you pick them up? We also don't have enough capacity as far as the testing laboratories are concerned. With this, what we are doing is we do contact tracing. So what happens is if someone is infected, then you have to look around the person and then test those that possibly might have come into contact with him or her. So getting the results on time is very, very important in the fight against this pandemic. I think I heard on your platform, I think yesterday's news also, where someone was saying the person was tested and I think he had the results 6 days later, and it was positive. Such contacts are not isolated. They are left in the community until the result comes out. And we know that days before such persons develop symptoms, even if they will, they are still able to pass the infection on to persons. So if someone will have to wait for the result for 6 days, by the time the result comes, that person would have infected as well. We will look for those contacts, go through the same procedure, take their samples, leave them in the community, and wait for their results. So it's like we will solve one problem, and then we'll move to another problem. So if we have the capacity, ideally, all contacts should be quarantined, so that if your result comes and you are positive, we would have limited the number of interactions we would have had in order to be able to record the numbers fewer than we would have recorded if you had been left. So I think the whole plan has to do that.
Quarantine where? Over 30,000 contact traced. Quarantine where?
Yeah. That is a problem. I think for now they try to let themselves quarantine. But if you are self-quarantined in a single room where you share facilities with 6, 7 people, then it's no quarantine. It's no quarantine. But as I said, we have limited resources, so we are unable to do it. But the best practice would have to isolate contacts until their results are.
Now, there are related issues about exempted workers. But these exempted workers are public health workers, and they are frontline workers. Do you have any information? Because I don't. All the public health people I've spoken to, either they work at OPDs or they are pediatricians or they work at adult emergencies, are not tested. Even though over the last 2 months, they've been looking at patients, whether having symptoms of ordinary flu or COVID-related symptoms, etc., but they are not tested. As a public health person, is that a worry for you?
Definitely, it is a worry, especially when we are talking of inadequate PPEs and all those things. Because if a practitioner is infected, look at the number of patients that are taken care of by a single practitioner in a day. If that practitioner is infected, then it means all the patients that he has attended to are at potential risk. We've been having cases of healthcare professionals going down with infection in the US, the UK, and other places. So Ghana is not immune to that. So I believe those that come into contact on daily basis with patients, at least there should be some kind of measures in place to ensure that they are tested periodically to be sure they are free of it.
The reality of our situation is that once you move out of Accra and Kumasi, or the major centers, or let's say Accra, Kumasi, and Tema, healthcare, the system and its delivery is weaker or porous in structure and in efficacy. How does that pose a danger to trying to have a turnaround time in detecting and ultimately bringing cases to the fore, to the center?
Take it again.
When you move out of Accra, Kumasi, and Tema, healthcare, its delivery becomes not as strong. How does that pose a problem to the whole structure of either it's a contact to be traced, trying to get tests done, and getting to make sure you undertake investigations correctly?
Contact tracing shouldn't be a problem, because it doesn't depend on the healthcare structure. But testing and management of cases is what is a problem. If you look at the incident that happened in, I think, the central region, we had over 2 months to plan for this, but we waited for a case to rear its head in central region before we are now looking for an isolation center. We are saying that timely results is key in the fight against this pandemic, since we are not quarantining the contacts. So if you have a case in, say, Upper West, for example, a suspected case, the closest they can take is KCCR. That may take hours. KCCR also has a map cases they are working on. So the case from Upper West join a queue. By the time it's ready, days have elapsed. That person might have contacted me, and then we will be dealing with the higher numbers. For the management, most of these regions don't have isolation centers. If a person tests positive, it's now that they are going to put them in. And the more contact you have with such positive person, the higher the risk you getting the infection. So these places should have been ready as soon as he or she is with the management team is there to take care of it. And then we limit the risk of infection to everyone, rather than waiting for cases to get before we try to look at cases.
Okay, 2 more questions, then we wrap up. Now, the isolation centers that we have, we've seen resistance to using schools and other community centers. One, on the side of the argument of those opposing, do they have a case? And then what could be the implications if these, let's say, the schools and other grounds are used on public health?
Okay. Those opposing have no grounds. I believe the whole thing has to do with education. Public health is a concerted effort and informed choices by members of the community society.
Okay.
We live in a very traditional area where the role of opinion leaders, assembly members, chiefs, and other persons cannot be overemphasized. But it appears all the fights and then the policies we are making is at the central government level. We need to decentralize it as much as possible. Education must get to the grassroots in a language that they can understand. I am sure if we have educated them on the risks they pose to people in a community, if, say, a facility there is designated as an isolation center, and they realize how low the risks, there wouldn't be this kind of agitation. Ordinarily, politicians haven't really done a lot of good to the population. It has been lies, lies, lies. So even if they are saying it, the population will think they are lying. So this is the time they have to engage the chiefs, the assembly members, opinion leaders who are in touch with the people, for them to disseminate such information. I believe they will believe them better than we leaving it to the politicians to do some of these things. And to end it, the virus, for now, it is not airborne. You have to be in close contact with the infected person to be able to catch. So if they are put in a school dormitory, for example, where the school is fenced, it poses no risk to anybody even living outside of the school, not to talk of people in the community 200 meters, 1 kilometer away. And the virus also doesn't survive on surfaces forever. So assuming without even disinfection, these people are removed from the facility, and then they are reopened, say, a month later. By the time people get to the facility, these viruses would have been dead. But ideally, after they've been removed, I believe disinfection must take place. Once the place is disinfected, it is very safe for the public to do.
Okay. Now, speak to the ration or the food sharing that is ongoing, where we have millions of crowd at these distribution centers of food in communities, etc. What's the effect to public health? And then the national disinfection that we've undertaken, is it a good thing? So first, you speak to the effects of people milling around the distribution of food.
We know the virus spread faster in densely populated areas. So once they are crowded, the chances of an infected person spreading the disease to many is very high. That is why we've been practicing physical distancing. So if the person will practice physical distance at home, but when he comes out to collect food, he will not observe that, then it's as good as not imposing any restriction on the person at all. So those sharing the food, I think, must devise strategies of making sure this kind of overcrowding is halted as early as possible. Other than that, we are in for real disaster.
All right.
I think you asked another question also.
Yes, I asked another question about if you look at the state of the lockdown, would you want us to extend it, or perhaps based on your own observation for public health?
What was our objective in going into the lockdown? There must be a measurable quantity of results that when we attain, we know we have been successful. We don't know the number of persons infected in the community. So at what point in time will we be able to say we've been able to halt that? That may only happen if we begin to see a reduction in the number of cases we are reporting. As of now, I don't think we have reached our peak yet. We have to hit the peak before we will start falling reduced figures. So until we hit our peak and begin to reverse the trend, we will not be able to say for sure that we need to put down. WHO is warning against countries lifting this lockdown very early, because all what you need is one or two asymptomatic persons in the community, and you spark another wave of epidemic. So in my personal opinion, until we get a vaccine I am afraid to say this fight will be a very difficult one. All what we can do now is try to minimize the number of infections so that our health system can cope with them. But to say we will be able to completely wipe out this virus without a vaccine, it may be difficult. Physical distancing would have been the cure to this pandemic. Because if everybody is isolated for 14 days maximum, those who have the virus and wouldn't even show signs or symptoms will recover on their own and therefore will not pose any threat to the society. Those who have and will show symptoms will definitely report and will take them out.
Yeah.
By looking at our current world and the nature of interaction, physical distancing or isolation cannot be done. So we may have to live with it like the way we are living with malaria, cholera, and all those things, and then try to strengthen our health system, minimize movement so that we wouldn't get enough, so that the systems can deal. Until we get a vaccine, this may be the best approach.
Well, thank you for a great discussion and some great education there. Dr. Paul Owusu-Oduro is a public health consultant and an expert. He is analyzing the situation based on his own data he has, information he's been looking at, and that observation as an expert. And when you look at it from that eye of a professional and somebody who has the technical knowledge, it helps in deepening the education, and that is what we do right here on the AM show. And please make sure that you keep the interaction ongoing. What's your own view on this? Facebook Joy News on TV is there. A Twitter handle is at hand. We have at Joy News on TV. Watch us live, My Joy Online TV on YouTube. Get the latest update, myjoyonline.com, on coronavirus and how we're covering this in real time.